The following podcast is part of a certified educational activity titled Modern Team-Based Therapeutic Management for Bladder Cancer Care. Expert strategies for integrating the latest evidence and treatment advances. Access the entire activity and complete the post-test at peerview.com/XSE860. Downloadable slides and practice aids are also available.
Hello, I'm Dr. Matt Galsky from the Icahn School of Medicine at Mount Sinai. I'm the Director of Genitourinary Medical Oncology at the Tisch Cancer Institute in New York, and I'm pleased to be joined by my colleague, Dr. Sia Danishman, Director of Urologic Oncology at the USC Norris Comprehensive Cancer Center in Los Angeles.
Thanks, Matt. I'm happy to be here.
Welcome to this educational activity entitled Modern Team-Based Therapeutic Management of Bladder Cancer Care, Expert Strategies for Integrating the Latest Evidence and Treatment Advances. So our goals for today are to increase your understanding of current and emerging data for the treatment of bladder cancer, including using bladder-sparing techniques, perioperative approaches, new approaches to drug delivery, to equip you with the skills that you need to use these approaches to care for your patients, and to provide you with guidance on how to support team-based management with the unique suite of adverse events associated with some of the current and emerging therapies that we use to treat bladder cancer. See, there's been a lot of advances in early bladder cancer. Can you take us through some of these challenges and exciting developments?
Yeah, happy to, Matt. As you said, there have been a lot of advances, but there's still a lot of unmet needs in the treatment of both non-muscle invasive as well as muscle invasive bladder cancer. We know that only a third of the patients with non-muscle invasive bladder cancer are given intravesical BCG. There are shortages in the United States and elsewhere that affects access to the drug. And close to half the patients with muscle invasive bladder cancer around the world may not even receive curative intent therapy. Patients who undergo radical cystectomy for muscle invasive bladder cancer have impaired health-related quality of life, have high risk of recurrence. So there's a lot of opportunities, I think, for improvement in care for bladder cancer across the spectrum of the disease. We need to develop effective, safe, and durable intravesical treatments that still remains a critical unmet need in this space. And for patients to avoid radical cystectomy for BCG refractory non-muscle invasive bladder cancer. The effective approaches post-radical cystectomy are also important in lessening the risk of recurrence, which happens in up to 50% of patients after intended curative therapy. So we do need a team-based care for patients with bladder cancer. There are a number of FDA-approved agents and clinical trials underway right now. It's an exciting time. We've changed the approach to the management of bladder cancer even in the past few years, as you and I both well know. And that goes really across the entire disease spectrum. Urologists are often the first point of contact for the patients, and they really need to be familiar with this fast-moving space of the available treatment options, and it is moving fast. Patient education is key. I think a lot of patients are more savvy these days. There's more resources for them to look up what available treatments are to recognize and manage both the drugs as well as the adverse events associated with the drugs. So with that, the Beacon, the Bladder Cancer Advocacy Network, which you and I are very involved in, is an excellent resource for both professionals, patients, as well as caregivers. I have the pamphlet in the clinic, and I give the pamphlet to the patients. It's got excellent resources for both the patients and the caregivers. It's got figures in there and the algorithm and what I say, the language that the patients need to learn to sort of understand their treatment. So it's great. It's got podcasts and treatment matrix, clinical trials dashboard that patients can look up on the website. So I think it's a really good aid. I think you use it as well. So high-risk non-muscle invasive bladder cancer is defined as anyone with high-grade TA, NET1, or CIS patients. The standard of care is 2-RBT and, as we mentioned, BCG. Prognosis is not very good for those who don't respond to BCG or relapse within 12 months. And these patients typically are directed to radical cystectomy. That's what we've had in the past. The criteria for definition of adequate BCG is defined by the FDA and several key publications that establish what we mean by BCG unresponsive disease. So adequate BCG is for induction is more than 5 installation of BCG and more than 7 installations within the 9 months of the first installation. So basically, what we say an intended 6 plus 3, or 5 of the 6 and 2 of the 3 within the year. BCG unresponsive high-risk non-muscle invasive bladder cancer is defined as any one of the following: stage progression. That's obvious. If you progress from high-grade TA to T1 on BCG, that's not working. High-grade T1 disease at the first evaluation after adequate BCG, so T1 to T1, for instance. Persistent high-grade non-muscle invasive bladder cancer 6 months after adequate BCG. And remember, again, adequate means at least 5 of the 6 and at least 2 of the 3 maintenance doses. Or recurrent high-risk non-muscle invasive within 9 months of the last BCG dose, despite getting adequate BCG. So what do we have in this space? This was one of the first new drugs that became available to us. This was based on the Keynote 57 Cohort A Pembro monotherapy for BCG unresponsive high-risk non-muscle invasive bladder cancer. And you can see that this was really a first departure from that 10 to 15% response rates for valrubicin that we were used to seeing. And we're seeing that, CIS plus minus papillary disease can be treated with systemic immunotherapy with CR rates of up to 40% initially. And some of that is durable. You can see up to 24 months of the 39 responders, about a third of them remained in CR for more than 18 months, and 23% remained in CR after 24 months, 2 years, which sometimes when you're dealing with an older population is quite significant. So no new safety data risks were identified in this trial. So this is an FDA-approved treatment option. This was approved in January 2020, and so we still have this in our armamentarium. But we have newer drugs coming in for intravesical therapy. One of them is natafaragene firadenovec. This is a non-replicating adenoviral vector-based gene therapy. Basically, what it's doing is delivering the gene for alpha interferon 2B into the urothelial cells, and the urothelial cells are then producing alpha interferon into the urine for sustained sort of release of this, which then directly and indirectly affects has an immunomodulatory effect, inhibiting tumor growth. So this was based on this gene therapy was based on this approval on the phase 3 trial. The drug is called etstiladrin, or natafaragene firadenovec, if you want to say the full name. And it was really the first gene therapy approved by the FDA for treatment of adult patients with high-risk BCG unresponsive CIS plus minus papillary disease. So again, most of these drugs are CIS plus or minus papillary disease. You have to have CIS in there for these FDA approvals. And this was approved in December of 2022 based on this trial. 55 of the 103 patients on the trial who had CIS with or without papillary disease had a CR within 3 months. And then the response was maintained in about half those patients, about 45 patients at 12 months. At 36-month follow-up, you can see that the probability of maintaining a CR was about 34%. So again, there's obviously always drop-off in these, but you can see that there's sustained response for a substantial portion of these patients out to 3 years, which is really what we look at. We look at that 2 to 3 year mark for efficacy of any drug. And duration of response is about 9.7 months. So this is available to us. I've started using this. It's very, very well tolerated. And so it's encouraging to have one more drug in our armamentarium for intravesical use. So we're going to be looking at this in a real-world setting, trial registry of sorts that's going to be opening in several centers. It's called ABLE 41. It's a real-world evidence study. Basically, we're going to enroll patients in this, anyone who's undergoing etstiladrin use. And it has questionnaires for both patients as well as caregivers and the practitioners as well, to see what the ease of use is and sort of get secondary data on AEs and efficacy and so on and so forth. So looking to enroll about 200 patients. We just opened this at our center, so I'm pretty excited about this to kind of get some prospective data. Okay, so what other investigational strategies are there available? So we're now testing the addition of IO or checkpoint inhibitors to BCG. There are two key trials here. One's the Potomac trial. looking at high-risk non-muscle invasive bladder cancer. Again, these are the standard high-risk patients undergoing either in 3 cohorts, BCG induction only plus durvalumab, BCG induction and maintenance plus durvalumab versus BCG induction and maintenance BCG. So 3 arms in this cohort. And then the Keynote 676, same patient population, high-risk non-muscle invasive bladder cancer that recurred after induction BCG therapy only, testing further BCG plus pembrolizumab versus BCG alone. These are large trials and hopefully will answer the question of whether addition of checkpoint inhibitor is more efficacious than BCG alone, and whether the addition of the AEs is worth the improvement in therapeutic efficacy for this disease. So there are other drugs also in development. One of them is the oncolytic adenovirus, cretostimogene grenadenorepvec. These names are quite something. But this is an oncolytic vaccine. It's engineered to express GM-CSF and replicate selectively in tumor cells with mutated deficient RB. And we know that RB is one of the pathways that is omnipresent in bladder cancer. So this is the phase 3 Bond 3 trial looking at intravesical CG for short, 0070 monotherapy for patients with high-risk BCG unresponsive disease. And you can see CR rates of 76% at any time. And then you can see at 3 months and 6 months, you have 63%. And many patients are having duration of response greater than 6 months. Okay, so another advance in therapeutic strategies is this new delivery system called the TAR-200 intravesical drug delivery system. So basically, this is a device that's placed in the bladder that allows for sustained release of gemcitabine into the bladder, increasing the dwell time of local drug concentration. This has been really widely implemented and being studied in multiple trials called the Sunrise studies, and we have Sunrise 1 through 5 currently. So this was the first that was presented. This is Sunrise 1. It was a phase 2 trial, basically in the same BCG unresponsive population, CIS plus or minus papillary disease. And there were 3 cohorts. The cohort 1 was TAR-200 plus citrilimab, which is a PD-1 inhibitor. Cohort 2 was TAR-200 alone. And cohort 3 was citrilimab alone, to really tease out and see what the individual components of these drugs are. And it was a 2-to-1 randomization. And there is the 4th cohort that opened later for papillary-only disease. So the primary endpoint for this was the overall CR rates. And there's been a lot of excitement with these because of these types of results. So this is the presentation. So far, the data we have: BCG unresponsive, again, high-risk non-muscle invasive bladder cancer. CR rates for the first 23 patients that they looked at with TAR-200 alone has been about 77%. By investigator assessment is 80%. These are numbers we're not really used to seeing. You know, we're used to seeing 30% range and so on and so forth. So when we see numbers this high, we get very excited that this is working, and hopefully it will be sustained. And you can see the swimmer plot there. The median duration of response has not even been reached. I have several patients on these trials. I've placed a lot of these devices. I've been with this device since its inception in the phase 1 trials in 2016. So I can tell you it's very well tolerated. It's efficacious. I have patients out to more than a year with this. So it's very exciting to see this. Sunrise 3, similar devices, exactly the same thing, except this is now in the BCG naive high-risk non-muscle invasive bladder cancer, going into that space where, trying to fill in the gap for the shortage of BCG. So Sunrise 3 is any patient that you would think of giving BCG, anyone with high-grade TA, T1, who's never had BCG before. They would get randomized between TAR-200 plus citrilimab versus group B would be BCG at the usual 6-week induction plus maintenance. And then there's a group C, which would be TAR-200 alone. So again, kind of breaking up the components to see what the individual contribution is. And the primary endpoint is event-free survival from randomization. Moving on to targeted therapy, we know that FGFR mutations are frequently observed in bladder cancer, and it changes from non-muscle invasive to metastatic disease. So basically, these are more prevalent, the mutations, in low-grade disease and non-muscle invasive disease. You can see about 60% or so of the non-invasive papillary carcinomas harbor these mutations. The high-grade T1s are about 30%, similar to what we see in muscle-invasive bladder cancer, somewhere in the 20 to 30% range. And then in the metastatic setting, it's about 20%. But this is important because we do have targeted therapy for these drugs. And I think it's important to discuss genomic testing with patients, particularly now that we have targeted therapy available for FGFR3 altered tumors. So the database analysis of over 700 eligible patients has shown that fewer than half the patients are undergoing testing. Importantly, those who were tested had 21% of those patients had an FGFR3 mutation, but only 42% of them are receiving the FDA-approved erdafitinib as an on-target therapy. So I think it's important to have these conversations early and specifically test tumors for FGFR3 alterations, or do a more comprehensive approach like just any of your favorite NGS panels or liquid biopsies, so that we have the full range of available therapeutic options for the patients going forward. So moving on into the trials that use this, this was part of a THOR-2 study looking at oral erdafitinib versus intravesical chemotherapy for, again, that BCG unresponsive high-risk non-muscle invasive bladder cancer. 3 cohorts, papillary tumor only with CIS with or without papillary tumor, or cohort 3, the intermediate risk non-muscle invasive bladder cancer with papillary tumor. These are the recurrent low-grade tumors or very small high-grade Ta tumors less than 3 centimeters, with the primary endpoint being recurrence-free survival. Again, this is oral erdafitinib versus intravesical chemotherapy, and you can see the KM curve there with the erdafitinib having quite a bit of efficacy in this setting, particularly in the low-grade tumors that harbor more of the FGFR3 mutations. Now, everybody had to have the FGFR3 mutation in order to get into this part of the trial, but you can see that it is efficacious. However, it does come at a bit of a cost in terms of AEs, but nevertheless, this was sort of the segue for us to move into erdafitinib intravesical delivery, so avoiding those systemic side effects. And that's exactly what the TAR-210 device is doing in this trial. So basically, you went through the molecular eligibility, and patients are randomized between cohort 1 and cohort 3, which is high-risk non-muscle invasive bladder cancer, again, that BCG unresponsive or even BCG experienced. You have to have a complete resection of all visible disease. And cohort 3 was the intermediate risk patients with recurrent low-grade TA tumors. This is the AUA definition of intermediate risk, and a visible target lesion prior to treatment. So what's interesting about this, we're leaving a little bit of low-grade tumor behind after our TURBT to make sure this is working. And of course, this is very safe because progression rates are very, very low in low-grade disease. And then we assess for disease response every 3 months. And the interesting thing about this device is that it can actually stay in the bladder for up to 3 months. And in fact, it is 3 months in this trial. So this is moving on into another trial called Moonrise 1. So we're really excited to deliver additional therapy for patients with intermediate risk bladder cancer, which has really been a big unmet need as everyone had been focusing on high-risk patients. Again, this is extremely well tolerated. It provides sustained release in the urine over 90 days with very low plasma concentrations. And you can see the hyperphosphatemia that just doesn't happen in the local delivery as it does with the oral erdafitinib. And so plasma concentrations remain very low while urine concentrations are high, exactly what we need for on-target therapy. And it has a very high rate of response, a small number of patients, but still in the FGFR3 altered. For cohort 1, the recurrence-free rate was 82%. And for cohort 3, 87%. It's really amazing. The first time I put this device in, you're looking at a tumor, and literally within 6 or 8 weeks, this tumor had completely disappeared. We were taking photos for photo documentation of these lesions, and you can just watch these low-grade tumors disappear with this. So very, very exciting. And we look forward to the larger scale Moonrise 1 study, which will open shortly at multiple centers. Again, extremely safe. The AEs are very, very low. Most of them have to do with everything we're used to with intravesical delivery of any medicine, which is the irritated voiding symptoms, but we're just not getting the systemic side effects. You can see that the grade 2 AEs are extremely low in this setting. So what about bladder preservation? Sunrise 2 is TAR-200 plus the PD-1 inhibitor citrolumab versus concurrent chemoradiation, which is standard of care, another standard of care for muscle-invasive bladder cancer. These are, again, patients with muscle-invasive disease who are either not eligible for cystectomy or don't want a cystectomy. They get randomized between these two treatments. And for the chemoradiation, you can give basically investigator's choice of the chemo. These are just radiosensitizing. And then the other arm is citrolumab plus TAR-200, exactly what we're doing in the other trials. So really trying to test this combination of TAR-200 plus citrolumab in the entire spectrum of disease, from BCG naive to BCG unresponsive to now muscle-invasive disease. Again, I can tell you that this is very exciting. I have several patients on this trial who are very, very happy to have kept their bladder and not have to have a cystectomy or radiation or any other therapy other than TURBT plus this device. And this is put in every 3 weeks for the first 24 weeks, and after that is quarterly for 2 years. So again, very exciting. It's very well tolerated. So patients are so far really liking this. So what about harnessing IO for trimodality therapy? Of course, that's being looked at as well in the Keynote 992. That's Pembro plus chemoradiotherapy versus chemoradiotherapy alone, seeing what the addition of Pembro might be to chemoradiation in this setting. Again, muscle-invasive bladder cancer, randomized 1-to-1 between Pembro plus chemoradiation versus placebo plus chemoradiation. Large trial, over 600 patients. And then we do our usual assessments and look at the outcomes with cystoscopy, cytology, biopsy, and imaging, as we always do. So that'll be exciting. And there are other trials in that setting as well. What about TURBT plus chemo immunotherapy alone? Dr. Galsky was the lead and head and spearheaded this amazing study looking at GemCis plus Nivo for 4 cycles as a neoadjuvant type of therapy for patients who were destined to undergo cystectomy. Those who had a complete response had the opportunity to keep their bladder with strict and very close monitoring to see whether we can save some bladders. And you can see the numbers there. There were 72 patients, and of those 72, 33 had a complete response, so just under half had a clinical CR. These were strict biopsies, urine cytology, imaging to make sure that it truly was a CR. And only one of those patients had a cystectomy. Sorry, Matt, that was one of my patients. Really wanted his bladder out. But the other 32 decided, no, they'll keep their bladders. And they did quite well. You can see the clinical, CR rate was 43%, and these patients have done extremely well. The other ones who didn't have a complete clinical response, most of them went on to cystectomy and others to non-protocol therapy. Okay, so let's go through a case discussion. This is a patient with non-muscle invasive bladder cancer, 68 years old. Performance status is 1. So not the healthiest. She's got papillary disease and is BCG unresponsive. Undergoes a TURBT and as resection of papillary disease. So currently disease-free, but BCG refractory. So what options do we have for therapy now? Let's say, Matt, the patient is referred to you for discussion or recommendations. What kind of discussion or recommendations would you have for this patient?
So oftentimes when I'm referred a patient like this, it's because there's been at least some consideration for systemic immune checkpoint blockade with pembrolizumab. So we know that pembrolizumab is approved for BCG-unresponsive non-muscle invasive bladder cancer. There were 2 cohorts in this study that led to the approval. One was in patients with carcinoma in situ with or without papillary disease, and the other was in patients with papillary disease. So it is an option here. I find that most of my patients with BCG-unresponsive non-muscle invasive bladder cancer in the context of expanding intravesical treatment options are somewhat hesitant to proceed with a systemic treatment with the potential for systemic toxicities. But it is the potentially right decision for some patients, a very personal decision. So we go through all the options in that setting.
Yeah, great. And we did mention gemcitabine and docetaxel as an option. Those are 2 approved, not FDA approved, but those are 2 options that we are currently using, intravesical sequential gem-dosi, that seems to have fairly good results based on retrospective studies of approximately 50% recurrence-free survival at 2 years. So that's one option if the patient doesn't want to be on a clinical trial. The other option is adstiladrin, nadofaragene firadenovec, which we mentioned. That's FDA approved and has, for papillary disease, about a 40% 1-year response rate. So certainly that's an option that's available. One of the advantages of patients' performance status 1, and we didn't specify why, but for patients who have trouble traveling to and forth from the clinic for various reasons, Nado is a one-time dose in 3 months. So that is very different than the weekly treatments that we do for all the other intravesical therapy. So that's one other advantage for the nadofaragene firadenovec. And then hopefully in the future, the TAR-200 device will be approved, and that'll be part of our armamentarium to instill into these patients, and that'll be once every 3 weeks, sort of like I said, for the first 24 weeks, and quarterly thereafter if the patient continues to have response. So lots of things to consider, and there are a lot of other combination trials coming on as well with both nadofaragene firadenovec and the other agents we mentioned. So we look forward to those results.
Neoadjuvant chemotherapy with cisplatin-based chemotherapy is the standard treatment for patients with muscle-invasive bladder cancer prior to going cystectomy. But there's a large amount of drug development taking place in different clinical disease states in bladder cancer, particularly with immune checkpoint blockade, as we've heard about from Sia in earlier stage disease. And so the logical approach has been to move those drugs earlier in the treatment in muscle-invasive bladder cancer. And so several trials are going on with neoadjuvant chemotherapy plus immune checkpoint blockade. In fact, we'll have more phase 3 clinical trials of neoadjuvant treatment in muscle-invasive bladder cancer read out within a span of about 2 to 3 years than we've had in the past 3 decades. So we're going to have a huge amount of data in potential practice-changing data. However, at this point, we don't have results from neoadjuvant studies either in cisplatin-eligible patients, as you can see here. And there's been 2 major strategies to combine cisplatin-based chemotherapy with or without immune checkpoint blockade, or to use the combination of enfortumab vedotin plus pembrolizumab, which I'm going to speak about a little bit more, versus standard of care neoadjuvant chemotherapy. So these trials will read out over the next few years and potentially change the way that we treat patients with muscle-invasive bladder cancer. In addition to those studies in patients with cisplatin-eligible disease, for the first time, we'll have phase 3 trials in patients who are cisplatin ineligible, trying to integrate perioperative systemic treatment. And again, 2 major strategies. One strategy has been to use the combination of enfortumab vedotin with immune checkpoint blockade prior to cystectomy versus cystectomy alone. And then we heard about Sunrise 4 already from Sia. And so very interesting approaches, potentially allowing us to, for the first time, integrate systemic perioperative therapy in patients who are cisplatin ineligible with muscle-invasive bladder cancer. Where we do have data already is in the adjuvant setting. So the studies integrating immune checkpoint blockade after cystectomy advance much more quickly than the neoadjuvant studies. We actually now have 3 phase 3 studies that have read out. Each of these studies were designed pretty similarly with a few nuances. So we have the IMvigor10 study, which randomized patients after cystectomy to atezolizumab versus observation. We have Checkmate 274, randomizing patients to nivolumab versus placebo. We have Ambassador randomizing patients between pembrolizumab and observation. You can see one of the trials here, Checkmate 274, was placebo-controlled. The others were open label. Each of these studies gave immune checkpoint blockade for a year after cystectomy, and they all use almost identical eligibility criteria. So patients who were at high risk for recurrence after radical surgery, and that included patients with T2 or higher disease if they had received neoadjuvant chemotherapy, or T3 or higher disease if they were cisplatin ineligible or declined cisplatin-based adjuvant therapy. Of these studies, Checkmate 274 met its co-primary endpoint, showing an improvement in disease-free survival in the all-comer population of patients with tumors with high PD-L1 expression. Ambassador met its co-primary endpoint of disease-free survival, and IMvigor10 did not meet its primary endpoint of disease-free survival. The reasons for different outcomes in these studies, there's a large number of potential reasons, including some subtleties of the designs of these studies. Here's Checkmate 274, and this is updated data from Checkmate 274. So now we have about 3-year median follow-up, and you can see here that there's a disease-free survival benefit as mentioned in the all-comer population, also referred to as the intent-to-treat population, with a hazard ratio of 0.71. And then in the subset of patients with tumors with high PD-L1 expression, and you see an enrichment of the effect in this population with a hazard ratio of 0.52. Overall survival in Checkmate 274 is a secondary endpoint, and we actually hadn't seen any of this data until EAU this year. And the OS data shown here are interim OS analyses that are pre-specified. Despite this being a secondary endpoint, it's being tested with statistical rigor. So this is a secondary endpoint, interim analyses. These analyses did not meet the pre-specified p-value thresholds for statistical significance, and so overall survival follow-up is ongoing, but you can see the trends here. And you see in the intent-to-treat population, the effect size for OS very similar to the effect size for disease-free survival, and the same thing in the patients with high PD-L1 expression with a hazard ratio for OS of 0.56. So the primary endpoints, secondary endpoints, and exploratory endpoints of Checkmate 274 all going in the same direction in supporting the use of adjuvant nivolumab. Here's the Ambassador data, and as mentioned, there was a disease-free survival benefit with adjuvant pembro versus observation. Here's the OS data. This is interim OS data from this study as well. We're not seeing the exact same trend, but this is early data, and we need longer follow-up to be able to fully assess overall survival in the Ambassador study. So immune checkpoint blockade in patients receiving perioperative therapy in particular, these patients by definition do not have burden related to the presence of cancer because by definition they're being treated in the adjuvant setting without evidence of cancer. And so trying to minimize treatment-related burden in patients receiving adjuvant therapy in particular is critically important. One way to potentially do this is to limit the amount of time that patients need to spend at the doctor, and in particular spend in the infusion units. And so there is an approach to development of subcutaneous administration of immune checkpoint blockade rather than intravenous administration. And this is now being pursued in multiple programs from different companies. You can see different phase 3 studies listed here integrating subcutaneous immune checkpoint blockade. And we actually have data from a non-inferiority study in kidney cancer that was presented at ASCO GU this past year. Here you see nivolumab sub-Q versus standard intravenous dosing. And you see the administration time. It takes about 5 minutes to receive subcutaneous nivolumab versus the approximate 30 minutes to receive intravenous therapy. And this adds up when you're getting treatment once a month. And so this study met its non-inferiority endpoint. Treatment was administered much more quickly with subcutaneous dosing. And I think we're going to be seeing more of this, particularly in patients receiving single-agent immune checkpoint blockade, and particularly in patients receiving treatment in the perioperative setting. So let's talk a little bit about a case. This is a patient with muscle-invasive bladder cancer, 56-year-old woman. She's an athlete in excellent health. She develops hematuria, has it on and off. She thinks it's related to her running. the so-called runner's hematuria, but it doesn't go away. And ultimately, she finds herself in consultation with a urologist, undergoes a cystoscopy, has imaging that shows a bladder tumor. TURBT shows clinically localized muscle-invasive bladder cancer. She has good renal function, no neuropathy, no hearing loss, and so she receives 4 cycles of standard neoadjuvant gemcitabine plus cisplatin, and then undergoes radical cystectomy. And her surgical pathology shows pathological stage T3B disease, and she has 0 out of 32 lymph nodes involved. So this is a woman who has received neoadjuvant cisplatin-based chemotherapy, has residual cancer in her pathology specimen. So what do you counsel a patient like this about? What do you tell them about prognosis, and what would you consider for this patient?
Yeah, so obviously it's had adequate neoadjuvant therapy and has had an adequate lymph node dissection, stage T3B. She's fairly high risk. The prognosis is about 50% recurrence-free survival at 5 years. This is a young patient, so obviously we're going to try to do everything we can to improve her survival. This is the ideal patient for adjuvant IO, i.e., based on Checkmate 274, which you just presented. I would be sending the patient to you for discussion of adjuvant nivolumab in this setting.
And how about ctDNA testing in this setting?
Yeah, I think there's emerging data, and it's exciting. We think that patients with ctDNA positive post-surgery respond better. We have a trial in IMvigor011 that's testing this in a randomized fashion with atezolizumab, but even within the IMvigor010 study that was presented earlier, the patients who were ctDNA positive, a cohort of that patient population responded really well to adjuvant IO, whereas the ctDNA negative patients did not respond as well. So I think there's emerging data, and you of course have designed a beautiful trial in this setting, the modern trial that we'll be participating in to really test out the effectiveness of adjuvant nivo and further adjuvant therapies in this setting. So we're sending it on all patients to learn more about it, get more familiar with the testing. I like the fact that it's quantitative and you can actually watch the ctDNA levels go down with therapy. And it's certainly prognostic, and hopefully we'll be able to stratify patients who need therapy versus those who don't in the future.
Excellent. And as Sia mentioned, Beacon, a wonderful resource for information in all clinical disease states of bladder cancer, but maybe in particular patients with muscle-invasive bladder cancer. Patients with muscle-invasive bladder cancer contending with multiple different treatment options, contending with the potential life-changing effects of multiple different treatment strategies that we employ, including getting used to urinary diversions, potential side effects of systemic treatment. So really a wonderful resource for information, Beacon. And I encourage all of my patients to connect and seek information there that they're not getting answers to in terms of things that they might encounter on a daily basis that might better be informed by peers.
Matt, can I just bring up one more point? These are patients who are going back and forth between the urologist and medical oncologist as we're still managing the postoperative surgical issues and stuff. And I think it's really important for urologists to sort of know about all the AEs associated with IO therapy so that they're not missed and attributed to the surgery. Patients with GI symptoms and diarrhea think, it's part of the diversion, but if the patient has ongoing diarrhea, they may have IO-related colitis. So I think it's important that urologists also learn about the various checkpoint inhibitor AEs as well.
I think that's an outstanding point in what I tell our advanced practitioners and our nurses when they're getting involved in our clinic and starting to learn about how we care for patients, is that a change in a patient's condition who's receiving immune checkpoint blockade, that's related to that immune checkpoint blockade inhibitor until proven otherwise. So we have a very low suspicion for working up any changes in condition, given the number of different things that can occur on these treatments. well tolerated in the vast majority of patients, but things can happen, and our teams need to know about that. In fact, it not only do our immediate teams need to know about it, but our extended teams need to know about it. And so most of our clinics have established a network of providers that help manage our patients, given the critical nature of multidisciplinary care in patients with bladder cancer, both in the muscle invasive setting and in the metastatic setting as well. And as our treatment armamentarium expands, the number of specialists that we've had to get involved in care continues to expand, given the side effects that can occur with new classes of therapies. We've been using platinum-based chemotherapy in the neoadjuvant and adjuvant setting and in the metastatic setting in urothelial cancer for a long time. We think perhaps that cisplatin-based chemotherapy is better than carboplatin-based chemotherapy based on years of data. But it wasn't until recently that we started to think that might have implications in terms of combination treatment with immune checkpoint blockade. And this really emerged because two randomized phase 3 studies combining immune checkpoint blockade with platinum-based chemotherapy in Vigor 130 and Keynote 361 did not meet their overall survival endpoints. And that was a bit surprising compared to what was happening in other tumor types where you would combine standard chemotherapy with immune checkpoint blockade, and it would be a winning strategy across the board. So that led to a lot of head scratching about why bladder cancer was different. And one of the differences was that we pooled in our studies platinum-based chemotherapy. We pooled patients getting cisplatin and carboplatin, didn't think it would make a big difference. That was done for pragmatic reasons because it was hard to enroll trials in patients with metastatic disease historically. And what you could see here was a hypothesis-generating finding. And that finding was that in patients who received immune checkpoint blockade combined with chemotherapy, there seemed to be a larger effect when immune checkpoint blockade was added to cisplatin-based chemotherapy versus carboplatin-based chemotherapy. And this is supported by some translational data suggesting that the immunomodulatory effects of cisplatin and carboplatin are indeed different. And so that really reinforces the Checkmate 901 study. And in Checkmate 901, patients with metastatic cisplatin-eligible bladder cancer were randomized to receive gemcitabine plus cisplatin or gemcitabine cisplatin plus nivolumab. So the only of these phase 3 studies to restrict the platinum backbone to cisplatin-based chemotherapy. And what we saw from Checkmate 901 was different from what we saw in those other phase 3 studies. We saw that it met its primary overall survival endpoint. You can see here an improvement in overall survival with a hazard ratio of 0.78. And gemcitabine nivolumab, gemcitabine cisplatin plus nivolumab was approved by the FDA as first-line treatment for metastatic urothelial cancer on the basis of these findings. Here's the progression-free survival data. You could see here, too, you see a significant improvement in progression-free survival with GemCis-Nivo compared to GemCis with a hazard ratio of 0.72, so a very similar effect size to OS. Here's the response rate data, and the response rate data is pretty interesting. The overall response rate is higher with the combination treatment compared to GemCis alone, 57.6% versus 43.1%. But intriguingly, the complete clinical response rate doubles. So you go from around 11% to around 22%. And not only is there a quantitative increase in the CRs, but there's a qualitative increase in those CRs as well. So we often think if you can get to a complete response, that's good, prognostically favorable. It might mean the same thing regardless of how you get there. But this data shows that that's not actually the case. And it depends how you get there. And so you see the box, the red box circling the median duration of complete response. If you have a complete response with GemCis, your median duration of complete response is 13.2 months. And if you achieve a complete response with GemCis-Nivo, your median duration of complete response is 37 months. So both quantitatively and qualitatively different in really trying to get to these durable responses that we hope to achieve in a subset of patients treated with cisplatin-based chemotherapy. And we know that this can happen with immune checkpoint blockade. And so trying to boost that tail on the curve that we've observed with cisplatin-based chemotherapy historically. The adverse event profile when we compare cisplatin-based chemotherapy with immune checkpoint blockade really represents the component parts of that regimen. So we don't really see synergistic side effects when you combine these two classes of drugs. We see chemotherapy-related side effects, as one would expect, and you see side effects related to immune checkpoint blockade in a subset of patients. And you can see here in terms of the side effects with Gemcis alone versus the side effects with Gemcis-Nivo, that the immune-related side effects, the side effects that you see with nivolumab in more advanced settings, you see occur in a subset of patients. So for the first time in decades, there has been an improvement in overall survival beyond what was achieved with platinum-based chemotherapy based on 2 phase 3 clinical trials that were actually presented in the same session at the same meeting at ESMO this past year. So after decades without advances, back-to-back presentations in the same meeting is really quite remarkable. And so the EV-302 study randomized patients with metastatic urothelial cancer who are treatment naive to the combination of an antibody drug conjugate, enfortumab vedotin, plus the PD-1 inhibitor pembrolizumab, so a novel regimen, versus platinum-based chemotherapy, and cisplatin or carboplatin could be used on EV-302. And here is the overall survival data. A marked improvement in overall survival with the combination. Here you see effect size of 0.47 for overall survival, favoring enfortumab vedotin plus pembrolizumab. And here's the progression-free survival data, similar effect size. You see how wide those curves are apart, hazard ratio of 0.45. And so a major step forward in terms of how we treat patients with metastatic urothelial cancer. And as I mentioned before, this regimen has been moved earlier in 2 large phase 3 studies in the neoadjuvant setting. Here's the response rate data with EV-302. And you can see the response rate was 67.7% with EV plus Pembro. In this response rate, in the context of smaller phase 1B experiences and then a randomized phase 2, if you will, the response rates held up really quite remarkably from those earlier studies to this phase 3 international study. And you see a complete response rate here of 29.1%. And so very effective regimen in metastatic urothelial cancer. Here's the treatment-related side effects. And you can see here that the side effect profile is a bit different with chemotherapy versus EV plus Pembro. With EV plus Pembro, we do see immune-related side effects, of course, related to Pembro. We see some of the unique side effects that can occur with EV, including a subset of patients experiencing hyperglycemia. We see rash with both Pembro and with EV. And so when you give them together, the risk of a rash is higher. And then we see peripheral neuropathy. And we think about neuropathy with platinum-based chemotherapy. And of course, we need to acknowledge that chemo in this trial is carboplatin-based or cisplatin-based. But we think about neuropathy happening with chemotherapy, but you can see here neuropathy much more likely with EV plus Pembro. And it's possible that this is related to the 2 different classes of drugs, but it's possible that it's related to duration of therapy as well, because with chemotherapy, we give up to 6 cycles of treatment and stop. And EV continues in the absence of prohibitive side effects and while it's working, and so could potentially be related to duration of treatment as well, because we know that neuropathy is a cumulative drug-related side effect. The other drug that we've heard about from C already is erdafitinib. Erdafitinib is an FGFR inhibitor that is effective in patients with tumors harboring FGFR alterations, either somatic mutations or fusions. And this phase 3 Thor study was really 2 phase 3 studies in one, and really addressed a critically important issue regarding sequencing of treatments. We don't have a ton of phase 3 data in urothelial cancer that helps us determine which drugs we should give in which order. So this is a really important study. So this study enrolled patients with metastatic urothelial cancer. They had to have FGFR3 alterations, and then depending on what they received previously, determined whether or not they were enrolled in cohort 1 versus cohort 2. So cohort 1, patients had received prior immune checkpoint blockade and platinum-based chemotherapy, and they were randomized to erdafitinib, the FGFR inhibitor, administered orally, or dealer's choice chemotherapy, which included docetaxel or vinflunine. Vinflunine is a novel vinca alkaloid not available in the United States. Cohort 2 involved patients who had not yet received immune checkpoint blockade, received platinum-based chemotherapy, so randomized patients between erda and pembrolizumab. There's been a narrative that patients with tumors harboring FGFR alterations might be less responsive to immune checkpoint blockade. That really dates back to some early data suggesting that luminal-like tumors were associated with more quote-unquote cold tumors and perhaps less responsive to immune checkpoint blockade. When that was subsequently looked at, asking the more direct question, do FGFR inhibitors portend worse outcomes with immune checkpoint blockade? At least retrospective exploratory data were not convincing in showing that, but that's been a narrative, and so that this trial is incredibly important in helping to understand this in a more prospective fashion. So cohort 1 of the Thor study, remember, these are patients who had received platinum-based chemotherapy and immune checkpoint blockade. And you can see here, this part of the study met its primary endpoint. There's an improvement in median overall survival with erda versus chemotherapy with a hazard ratio of 0.64, similar benefit with progression-free survival. And let's look at the response rate data. So with erdafitinib, response rate of 45.6%, and with chemotherapy, a response rate of 11.5%. So higher response rate, much higher response rate in this molecularly defined population, and improved PFS, improved overall survival, really reinforcing the critical role of erdafitinib in the management of patients with tumors harboring FGFR alterations. But what does this tell us about when patients should get this treatment? Well, that's where cohort 2 helps us a little bit. So these are patients who had received platinum-based chemotherapy but had not received immune checkpoint blockade yet. You see the response rate with erdafitinib in cohort 2 quite similar to cohort 1, 40%. And you see the response rate with pembro is 21.6%. So pretty similar response rate with pembro in this FGFR, in this cohort of patients with FGFR3 altered tumors, compared to what we see in an all-comer population treated with pembrolizumab in this setting. And so you see the survival curve here, and the early portion of the curve favors erda a little bit, but then you see the curves cross. There's not a significant improvement in overall survival with erda versus pembro here. And so when we think about sequencing, it certainly makes sense to consider giving platinum-based chemotherapy, followed by immune checkpoint blockade, followed by erdafitinib. However, of course, I showed you that the landscape's completely changed, and now enfortumab vedotin plus pembro is really a standard first-line treatment option. And in that situation, patients have already received pembro. Patients with FGFR3 alterations, certainly erdafitinib as a next line of treatment makes a lot of sense. There are class effects with FGFR3 inhibitors, and Sia already mentioned many of these. Hyperphosphatemia is a class effect, so we monitor that. That's manageable with diet and with phosphate binders. Ocular toxicities, on the other hand, a side effect that we're really not used to seeing with some of the other drugs that we give. This can include central serous retinopathy, presenting most commonly as blurred vision. So we have all of our patients see an ophthalmologist before starting this drug, and then have regular ophthalmology exams. And certainly if they experience any blurred vision, important to get them into the ophthalmologist. So let's circle back to a case. And this is a case of a patient with metastatic urothelial cancer. This is a 66-year-old man, presents with hematuria due to a bladder mass, has urine cytology, TURBT, confirmed urothelial cancer, and then has a CT of the chest, abdomen, pelvis, has multiple retroperitoneal and pelvic lymph nodes measuring 2 to 3 centimeters in size. His creatinine clearance is 60. He has an ECOG performance status of 1. He's a current smoker, history of neuropathy, no autoimmune disease, not on steroids, no FGFR alteration. And so how do we think about this patient? Well, we already spoke about the fact that we have 2 regimens now that show an improvement in overall survival compared to standard platinum-based chemotherapy for the first time in decades. And so we have 2 regimens really to choose from. And of course, we have the older strategies that we used to use that are still reasonable as well in the context of a quickly shifting landscape. So Sia, if this patient went to see their medical oncologist, they get this diagnosis, and then they're coming back to see you, and they want your opinion, what do you tell them is important about some of the newer data?
Yeah, so this is interesting, Matt, because patient has what appears to be lymph node only metastatic disease. And retroperitoneal can mean anything from the lower sort of retroperitoneal, the aortic bifurcation, up to the renal hilum. I do think about them a little bit differently, and I think this patient potentially has a chance for actual cure. And you need to sort of frame that with a hope that with multimodality therapy, potentially you can cure them. Now, you could easily go to EV Pembro as your first line therapy for metastatic disease with, potentially 29% Harrod's cure rate for this with systemic therapy alone. But this is a patient I might think about doing Gemcis-Nivo first in consultation with our medical oncologists and then seeing if a patient is appropriate for surgical therapy, i.e. taking out the bladder and the lymph nodes, provided the retroperitoneal lymph nodes are lower down. Once you get up to the renal hilum, I think the curability of the disease is much lower. But if they have a good response to Gemcis-Nivo, then perhaps, that patient could be eligible for surgery and really reserve EV Pembro for later metastatic disease. So that would be one approach, I think, to just not knock out surgery as a potential for consolidation therapy here.
Yeah, I think those are great points. So this is a patient who has kidney function that's right on the borderline there, has a history of neuropathy, so we have to think a little bit about the potential effects of EV Pembro versus cisplatin-based chemotherapy. And then, as you point out, as lymph node-only disease, we know from both studies, we know historically that lymph node-only disease is a favorable prognostic factor. That probably represents a unique biology that's associated with lymph node-only disease. But we also know from the two studies so far that having lymph node-only disease, even though it's a favorable prognostic factor, the effect of the newer regimens compared to the older regimens is still amplified. So you still see that large effect of EV Pembro versus chemo and Gemcis-Nivo versus chemo in patients with lymph node-only disease. And so, yes, a population of patients that historically we think might be curable, and trying to even increase the likelihood that we could cure these patients with more modern regimens. And so I think we're seeing a lot of promise with these two regimens, particularly in patients with lymph node-only disease. And we need to be thinking about the very things that you mentioned. Is there a chance for cure? How do we think about balancing the morbidity of consolidative surgery in a patient like this? Clearly both medical considerations and very personal considerations from a shared decision-making standpoint.
Now, Matt, can I ask you a question? The patient has a history of neuropathy and it doesn't really specify how much or what grade. And how do you think about that when it plays into choosing between EV that tends to have a little bit more neuropathy than cisplatin-based therapy?
So the neuropathy with both is related to cumulative exposure to drug for the most part. And so grade 1 neuropathy not necessarily impacting my decision between the two regimens. A patient with grade 2 neuropathy, cisplatin-based chemotherapy, we need to be a bit cautious there as well. But I might lean a little bit more towards cisplatin-based chemotherapy the worse the neuropathy is. And of course, if the neuropathy is so severe, both of those regimens, we need to think carefully about whether or not that's the right thing to do for patients. And I think that's why the goals of treatment are, of course, critical in terms of making that call. And in patients with lymph node-only disease versus visceral metastatic disease, that probably enters into the equation as well. So there's a number of clinical trials available to our patients across many disease states. How do you talk to patients about clinical trials? Particularly now with all of these treatment options that we've spoken about, clinical trials remain critical to our developing treatments that we'll be able to use in the future to even increase the likelihood of cure to a greater degree. So how do you talk to patients about trials?
Yeah, that's a great question. And I think, we need to really bring this up early in the discussion. So at the very first consultation before TURBT, that's part of my consultation is, we have many treatment options available. You're at a center that has many clinical trials with novel agents that are not approved yet, that are promising. And so it's introducing this language early on in the discussion and bringing them back and saying, okay, now we have this, this, and this, like I talked about before. These trial options are very important. I think people need to start thinking that trials are not experiments of medication, but rather actual treatments that are very promising. And I go through what has been approved, and every drug that has been approved for cancer therapy has gone through some clinical trial that showed benefit of that drug. So I think it's incumbent upon the urologists who start the journey for the patient to start telling patients early on so that they're thinking about that. The savvy patients and organizations like we can help a lot because they have the language there for the patients to understand that these are potential novel therapies that can be improve their chances of survival. So I do direct them to those websites, but also kind of let them know in lay language about all the drugs and that we currently use has gone through some process of a clinical trial to get the FDA approval.
Great. And for virtually every clinical decision that needs to be made across clinical disease states of urothelial cancer, a clinical trial should be on the list of potential options. Remember all of these incredible tools available through the Beacon website, including the clinical trials dashboard. So navigating clinical trials, despite some national registries of clinical trials, it gets really difficult to navigate clinical trials for an individual patient given the nuances of different clinical disease states. And so the clinical trials dashboard on the Beacon website really tries to overcome this and is really an incredible resource for our patients. So thanks for joining us today. In summary, we've seen the evidence that supports numerous approaches in the treatment of our patients with bladder cancer, learned effective approaches for integrating them into clinical care. Thanks for joining me, Sia, and really incredible amount of information coming out, beautifully summarized by you.
Thanks, Matt. It's really a pleasure. It's great to be here. Always great to be with you. I always learn from you as well. Please remember to download the practice aids with this educational activity as a resource for you, your staff, and your patients. And thanks again. We hope that you found this activity informative and useful for your practice.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/XSE860. This activity is supported through educational grants from Bristol Myers Squibb, Ferring Pharmaceuticals Incorporated, Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC, which are both Johnson & Johnson companies, and Merck & Company Incorporated.